Okay, this is fabulous. We'll get started here. So hello, everyone, and welcome to tonight's pep talk, Navigating Post-Thrombotic Syndrome, CTEPH and CTED. I want to thank my co-host, Todd Robertson, and our clinical guest, Dr. Tim Fernandes, for joining us here tonight. Before introducing Dr. Fernandes, I would like to remind everyone that we are not here to give medical advice. We are here to provide medical information and education only. Every patient is different, and you should discuss your specific health journey with your doctor. But we do hope that we give you information tonight so that you can have a very constructive conversation with your clinician. So with that, I'd like to introduce our clinical guest this evening, Dr. Timothy Fernandes. He is a clinical professor of medicine and director of comprehensive pulmonary embolism care at the University of California, San Diego. Dr. Fernandes received his BS in biology, magna cum laude, from the University of Dayton, his MD from the University of Cincinnati College of Medicine, and his master's in public health from San Diego State University. Dr. Fernandes is a member of the Critical Care Committee and Pharmacy Anticoagulation Committee at UC San Diego Medical Center. He is a member of the American Thoracic Society, the American College of Chest Physicians, the International Society of Heart and Lung Transplantation, and the Pulmonary Embolism Response Team Consortium as well. Dr. Fernandes has been involved in numerous clinical trials. I think I counted 15. Is that correct? Worldwide. I lost track too. 15, more than 15 clinical trials, and has been published numerous times on this very important topic. You truly are a world expert on tonight's topic, and we are so delighted and thankful to have you here with us. Before we get started, though, we are going to kick it back to Todd, who's going to lead us through some poll questions, and then come back to me, and we're going to get the party started.
Thank you, Leslie. Good evening, everyone. We've got a fantastic guest tonight, and this is awesome. We do have some poll questions for you, like we normally do. We're going to have a couple for you. We're going to have 3, and we want you to answer those, and then we'll review the results, and then we're going to have an exit poll as well at the end of the show. Have you ever been diagnosed with any of the following conditions? CTEPH, CTED, PTS? No answer. Second question, did you feel your condition was adequately explained to you by your clinical team? Yes, no, unsure, no answer. Have you received surgical treatment for any of the following conditions? Check all that apply, please. CTEPH, CTED, PTS, no answer. We will look at the results once those come up. All right, let me scroll back up to the top. Have you ever been diagnosed with any of the following conditions? CTEPH, 8%, CTED, 7%, PTS, not surprising, 31%, and no answer, 63%. Excuse me. Did you feel your condition was adequately explained to you by your clinical team? I wanted to see the results on this. 10% said yes, 45% said no, and 11% were unsure, 30% no answer. Have you received surgical treatment for any of the following conditions? CTEPH, no one responded there, 0%. CTED, 1%. PTS, 5%. And 95% with no answer. So thank you for answering those questions. We'll do the exit poll at the end of the show, Leslie.
Okay, great. We started our conversation a little bit earlier amongst the 3 of us talking about people may have not been adequately diagnosed, so those numbers could possibly be actually incorrect. Okay, so with that, I know Dr. Fernandes, you brought some slides to share with us today.
Yes.
And our first question tonight is going to be if you could actually start with it. And also, what type of doctors treat this? Because a lot of us get treated by a wide variety of different doctors. And so who's involved in this diagnosis and treatment?
Sure. Yeah, so, I think everyone here that is in the audience has had some form of venous thromboembolic disease. So typically, let me see if I can share my slides here. All right, you seeing that?
Yes.
Let me see. Okay. So typically, when you first have a blood clot, they tend to form in the deep veins of the legs and the pelvis. Some people have upper extremity clots or jugular vein, but those are less common. And those clots can break off, and the lungs are a good filter. The pulmonary arteries see all of the blood flow. And so frequently we are capturing these clots in the pulmonary arteries as pulmonary emboli. And what I don't think a lot of people understand, and I can speak for myself as a medical student, I didn't understand that that's just the first time that patients come to our attention. I remember when I was an intern making a diagnosis of a PE, it was almost 20 years ago now, and we were in the hospital by ourselves overnight, and we had to make a decision to go to the CT scanner. And we took a patient and made a PE, and I remember high-fiving my teammates in the morning for making this diagnosis. But in reality, the patient has to live with that for the rest of their lives. And it's not just that acute event, it's have they fully recovered from that pulmonary embolism? Have they fully recovered from that deep vein thrombosis? And what sort of limitations are they having that are due to residual chronic clot? That clot has now been replaced by some scar tissue. So when we're talking about residual chronic clot in the leg, we're talking about post-thrombotic syndrome. That's the chronic DVTs. And when we're talking about chronic clots in the pulmonary circulation, that ranges from chronic thromboembolic disease, where you have chronic clots that are leading to complications and leading to problems breathing, all the way to chronic thromboembolic pulmonary hypertension, where you've got these blood clots, these scars that are occluding those blood vessels and causing the pressure in the heart and in the pulmonary arteries to be very high. So I think it's really incumbent upon the physicians treating patients and following up patients after pulmonary embolism to really get to understanding how limited they are. Are they back to their pre-PE baseline? Or are they having residual shortness of breath, and figuring out, is that shortness of breath due to chronic scarring from their original blood clots?
Can I just ask you,
Yeah.
how long does it actually take for scarring to occur? So you
So
refer to it as chronic
let
scarring.
me show you a couple of slides and we'll get to
Okay.
that. So this is my contact information. These are my disclosures. And feel free to reach out to me or my clinical staff if you have questions or concerns. So we talked a little bit about this. Clots start in the legs. They tend to start right below these valves. And that's where the flow is a little bit more turbulent. And so the flow gets hung up here. They form a clot in their deep veins of their legs and pelvis. And then that forms this cast of a deep vein that can embolize and go to the lungs. And that may be where we first capture these symptoms. So, but once you have a blood clot, there's essentially a race that starts happening. And your body has its own intrinsic lytic system, enzymes that want to chew up blood clots. And so those are circulating and wanting to chew up these blood clots, either in the leg or in the pulmonary arteries. If somebody has a delay in coming to our attention and they're not put on anticoagulation in a timely fashion, at the same time that those lytic system is trying to chew this thing up, there are circulating white blood cells that see a clot where it shouldn't be and want to cover it with scar tissue. And once that scar tissue has been laid down, no matter how much Eliquis or Xarelto or Coumadin or whatever you're put on, that's not going to break down. It's become scarred. It becomes part of that vessel wall. So when we're talking about post-thrombotic syndrome, you have this clot that forms right under a valve. Over time, if it's been sticking around, how much time? I think it varies, but usually in a couple of weeks, you've started taking this red clot and starting to form this collagen scar that has more of this white tissue in it. And if you destroy those valves, then the pressures in the legs get very high and you can get swelling, you can get that discoloration of the legs, you can develop ulcers from poor venous drainage. And ultimately, it's due to this scarring that's inside that vessel wall that causes a lot of these symptoms. So we'll talk at the end a little bit about things we can do for post-thrombotic syndrome. Same thing happens for pulmonary embolism. So here's a clot that was sucked out with one of these suction catheters that we use for acute pulmonary embolism now. So this is a red clot. It's red blood cells that are trapped in a fibrin mesh and have platelets aggregating. Looks red when it comes out. When we take patients for surgery for CTEPH or CTED, they get this white stuff out, and this white stuff is collagen. So collagen is the same stuff that you have in chicken gristle. It's this white firm material. It's not red anymore like the fresh blood clot. It's now been replaced with this scar. So when we talk about chronic blood clots, people think about red things like this. It's really a white scar that's become part of that vessel wall. So what happens is when you have a blood clot, there are a lot of things that can influence whether or not you fully resolve. The good news is the majority of patients, when they have a pulmonary embolism, fully recover their perfusion. Their blood flow in their lungs goes completely back to normal. If you have a large clot at the time of diagnosis, if you had a delay in starting anticoagulation more than 2 weeks, if you have some of these inflammatory things or things that favor remodeling and favor scar formation, then you may form these chronic perfusion defects, and
So
those can cause.
before you go
shortness of
forward, I
breath.
just want to, let's walk through this in layman's terms for people.
Sure.
So
So,
the acute pulmonary embolism means you've had your PE, you've had your pulmonary
correct.
embolism. And the clinical factors are what may have caused it or what you may have.
These are things that are influencing whether or not the clot fully resolves or
Okay.
whether it becomes scar.
Okay. And can you explain to everyone what RV strain at diagnosis is?
So if you have a large pulmonary embolism, you can think of it, I explain it to patients like putting your finger over the end of the hose, the water shoots further. If you plug up a pulmonary artery, and the pressure is going to go up, and it's going to cause more high pressures in the pulmonary arteries. And the right heart, the right ventricle, is the chamber that's pumping that blood to those lungs in the pulmonary arteries, and it's not acclimated to high pressure. So that right heart can get big and dilated, and those are really sick patients when they come in with their acute pulmonary embolism.
Okay, thank you.
So this is a key concept here for PE. I think if you take all of everyone that's had a pulmonary embolism, and we ask you, are you back to your pre-PE baseline? Upwards of 50% of patients will say, I'm not fully recovered. I never got back to where I was the day before I went into the ER with that pulmonary embolism. So that's a really important thing for people to hear, that, we expect you to get back to normal, but if you're not back to normal, it's really incumbent on your physician to work that shortness of breath up and figure out why you're still short of breath. So half of patients never get back to their pre-PE baseline. If we were to do imaging, we'd see in about 30 to 50% of patients, they still have chronic scars from their original blood clots. They didn't fully resolve that perfusion. You can see here in this Venn diagram, there's this overlap in this sort of lime green area here, where not everyone that's short of breath has chronic scars, and not everyone with chronic scars in their pulmonary vasculature has shortness of breath. So we really need to figure out this lime green area. Are you short of breath due to the pulmonary embolism, the scarring from the pulmonary embolism? We do a lot of cardiopulmonary exercise testing. I would imagine that the minority of the short of breath post-PE patients in this call have ever had a cardiopulmonary exercise test, but we can talk a little bit about that and how to work this up. And what you're left with is this triangle here, this lime green triangle, where you have shortness of breath, persistent clots, and a cardiopulmonary limit. And among those patients, about 3% of patients, 3 to 4% of patients have chronic thromboembolic pulmonary hypertension. So I didn't see how many patients are on this call, but approximately 1 in 20 of those patients, if you've had a PE, are going to have chronic thromboembolic pulmonary hypertension at the end of it.
So it's quite possible that there are those of us who could actually have post-PE syndrome and we've just never been diagnosed.
Correct. Yeah, I think it's tremendously underdiagnosed. So the other part of this green triangle is what's called chronic thromboembolic disease. These are patients who have chronic clot, they're short of breath because of that clot, but they don't have resting pulmonary hypertension. Their pressures in their pulmonary arteries in their lungs are not elevated at rest. If we were to perturb the system and have them exercise, we'd see that those vessels are lined with this stiff chronic clot, and their pressures shoot up for a small bit of exercise. So walking to get the mail, you shouldn't get terribly short of breath doing that. But if your blood vessels are lined with chronic scars, they're stiff, and the pressures will shoot up when you're exercising.
Mhm.
So that's even more common than CTEPH. So CTED is about 10% of patients. So these are very common things that may happen. So upwards of more than 1 in 10 patients after a pulmonary embolism are going to have some sort of exercise limitation due to chronic scarring from that original PE.
And it's a
So
really interesting point you bring up because, I mean, Todd and I know this, and Todd in particular, dealing with so many patients, that exercise component is so important for people, and they're just not getting the advice that they need to develop some type of an exercise program.
yeah, I think it's really important to exercise. I think, there's a lot of research on cardiopulmonary rehab after a PE. I don't think you need to be that explicit where you need a respiratory therapist there watching you exercise. I think getting out and walking and trying to build your exercise tolerance back up is important. We don't want to go through this whole workup and just find out that you're deconditioned because you've been afraid to walk or afraid to go out. And that's a common thing. I think there is a lot of fear when you have a pulmonary embolism.
So when you have all these questions and you don't have a pulmonologist, say you're only seeing a primary, or you maybe have your hematologist, you can ask for a pulmonologist, right? Isn't a pulmonologist the one you want to talk to if you want to talk about, a cardiologist too, but exercise, the breathing function test, eventually they have to go to someone like you, correct?
Yeah, I think a pulmonologist and a cardiologist, really specialists in pulmonary hypertension, those are the people who typically are making this diagnosis.
Mm.
I'm out here trying to get the word out to primary care doctors and to hematologists that we should expect patients to get back to normal. If they haven't gotten back to normal, then referring them to a specialist who can work that up is very important.
Yeah.
I don't want people out there struggling for the rest of their lives when there are things that we can do.
Right.
So we're just at the tip of the iceberg here. So in the US, there's about 600,000 acute PEs per year. And if you look at some of the research that shows persistent perfusion defects, I said, 30 to 50% of patients. Well, if we conservatively say, 180,000 PEs perform these persistent defects, and 1% of the total has chronic thromboembolic pulmonary hypertension, we're expecting to find 6,000 cases per year, and we're nowhere near that. We're probably we are the largest center in the US in UCSD doing the surgery for this. We do 180 to 200 surgeries and another 100 balloon angioplasties. And if you add up all of the centers in the US, there's less than 1,000 total procedures done. And those are prevalent patients. Those are people who have already been diagnosed. These aren't new diagnoses per year. So this is a very common thing that we're missing. I shouldn't say very common. This is something that we're missing. And I imagine among people with shortness of breath after a pulmonary embolism, it is very common. So we just need to encourage doctors to do this workup and come to this diagnosis because there are things we can do to help.
So not to go off course
Yeah.
here, but a lot of times the doctor will not refer the patient. So what do you suggest to us as patients who feel that something isn't right and we want to receive treatment or see somebody else? Like, what do you recommend that we say or what we do?
Yeah, I think the squeaky wheel, gets the grease. I think if you keep saying something's not right, I am not back to my pre-PE baseline, I am still short of breath. I want more done to evaluate this. I think, we were talking a little bit about this before the talk, but I think people's shortness of breath is dismissed too frequently after a pulmonary embolism. we should, as a physician, we should never say, oh, it's, you're just overweight, or, it's asthma or something else that's more common. I think it's really incumbent on us to prove that it's not shortness of breath due to residual of that first blood clot. And I think patients really need to ask, say, how do you know that, my clots are gone? How do you know that this isn't something like CTED or CTEPH? Can we work that out further? And if your provider isn't willing to do it, they should refer you to somebody who's capable of doing those examinations.
Right.
Perfect.
I think this point will resonate with a lot of you in the audience.
Yeah.
The median time from the onset of symptoms of CTEPH to diagnosis is 21 months. So patients are given the runaround. They're saying, oh, you lose weight, do whatever that's more common. But the median patient sees 13 doctors or 13 doctor visits before somebody really comes to the conclusion that they have a chronic blood clot that could be causing their symptoms. So I really want to see that number come down. I want patients to advocate for themselves, and I want doctors to consider this diagnosis earlier so that patients aren't out there languishing for 21 months with symptoms of a disease that could be potentially treated.
This is really unbelievable. And so, having that 21-month period, are you past the point of no return at that point when you're finally diagnosed, or are there things that can be done? Because if you do have scarring, as an example, okay, you get diagnosed, but can something actually be done about it?
Sure. So let me jump to the next slides here. So yeah, I think there are things that we can do. The first thing is, we need to make sure that people are back to their baseline. If you're not back to your baseline, you got to be screened. Okay, so here are the steps to screening. This is an algorithm that we published here from San Diego. If you come to see me in my clinic, these are the steps that I would take to evaluate a patient for CTEPH and CTED.
Can you share with us what some of those questions would be?
So the scripted questions, really the most important one is this: are you back to your pre-PE baseline, yes or no? We have some scripted questions asking people to say, what was the most activity you did in the week before your PE? What's the most activity you do now? But the overarching question is, are you back to where you were before? And if not, then we work them up further. We do cardiopulmonary exercise testing. So this machine where we are monitoring patients inhaled and exhaled oxygen and carbon dioxide, heart monitors, and they actually exercise. If you tell me you're short of breath when you're doing activity, we got to make you do some activity to see why you're short of breath. So that's what we do. Not a lot of places do this. I would guess that the minority of patients on the call have ever had a CPET. And that's okay. There are other things we can do to make this diagnosis. If you're from a small local hospital system who doesn't have a cardiopulmonary exercise lab, this step can be skipped. So if you're not back to your pre-PE baseline, a ventilation perfusion scan is still the screening test of choice. So this is a nuclear medicine scan. On the top 4 images here, you inhale some radioactive xenon. So it's a noble gas that doesn't get absorbed or anything. And we take some pictures, and we can see that by 2 minutes, that gas is washed out of the lungs. And then they give you some radio-labeled albumin, and we see where the blood flow is going. And in this patient, here is their left lung. Can you see my pointer, by the way?
Yes, we can.
Okay. So here's their left lung, and they have this big black hole here where there's no blood flow going to those regions of lung. This is their right lung here, and the right base and the anterior part of the right middle lobe here is all out. They should have restored that perfusion to normal. And when you have these chronic perfusion defects, the next step is doing an angiogram. You can either do another CT scan to see the pulmonary arteries, or you can do a conventional pulmonary angiogram where we go in with a catheter and inject some dye and see exactly where these blockages are. Here on the left side, this left lower lobe is just totally out here in this patient. You should see blood vessels that look like this, sort of scary Halloween tree with like the scraggly branches. You should see that down into this left lower lobe. And this patient doesn't have any of that. They're missing some vessels here on the right side, And so we took this patient to surgery and removed chronic blood clot. This is what it looks like. And this entire right lower lobe, I'm sorry, this entire left lower lobe was totally occluded by chronic blood clot there.
Wow.
So patients can get back for perfusion to that lung. You can imagine this person was walking around, short of breath, working. They're breathing for 2 lungs, but they're only getting blood flow to a little over 1 lung. They're very inefficient. And by removing those chronic blood clots, we bring down the pressures and we make the system more efficient. You can get back to where you were before those original pulmonary emboli.
So can you just go back to that for a second? So the pulmonary angiogram was done how long after this person had a PE?
So typically, we want patients to be on anticoagulation for at least 3 months. Most of the recovery happens in that first month. In fact, a lot of the recovery happens in the first week or 2. But most of the recovery happens in the first month, and everything that's going to go away goes away within 3 months. So if by 3 months you're not back to where you were, then that's where I start working up, have you formed some chronic scar there? And is there something that we can do about that? So I think 3 to 6 months, that's the really key time point.
Okay.
If you're not back to normal, really harp on your doctor to start this workup.
Okay. So I'm sure, myself and probably the majority of folks on here tonight never had this exercise test or anything like that. Does that mean that the 6-minute walk that we all have had to take is irrelevant, or is that actually meaningful?
I wouldn't say it's irrelevant. It's not something that I routinely do. I think a 6-minute walk test gives you an idea of the functional limits that somebody has.
Mm-hmm.
But I think a cardiopulmonary exercise test is a better test. So
Okay.
that's where I would start. And then
if someone's on an anticoagulant and they have the angiogram, they have to stop for a day or 2. Is that right?
So typically if you come to San Diego, we would bridge patients with Lovenox injections, especially if we're going to consider surgery. We don't want somebody to have an acute clot. I'll describe how we do the surgery, but acute clot, it's like trying to pick up Jello with chopsticks. It just sort of falls apart. This stuff is organized and it become part of the vessel wall. So we want to make sure there's no acute clot when we're going to the OR. I also do an invasive cardiopulmonary exercise test. So if you don't have pulmonary hypertension at rest, I want to prove that that is what you have when you're exercising before I send you to a big open heart surgery. So this is a bike. This is me. We have a catheter here in this patient's neck. We're measuring the inhaled and exhaled gases, and we can see what happens to her pulmonary artery pressures when she exercises. I think, normally your pressures go up a little bit, but if you have a stiff clot that's lining that vessel, the pressures will shoot up when you just start a little bit of exercise.
And actually, before you go forward, can you go back for a second?
Yeah.
I just want to make sure we have our terminology correct. So VO2 is what exactly?
VO2 is the oxygen uptake. So if I have an Apple Watch, I don't know who has an iWatch, but your iWatch, or if you have a Garmin, a lot of those will report VO2. If you're an athlete, it's your overall fitness. And it's your oxygen uptake. So that's what we're measuring with the thing in her mouth, is how much oxygen she's breathing in. And that tells us how efficient the system is.
Okay. And the continuous measurement of what is that?
This is carbon dioxide. And so if you can imagine, you have to breathe, you're breathing out carbon dioxide. If you have to breathe harder to breathe out this, because you're missing blood flow to regions of your lung, if you have to breathe harder to get out the same amount of carbon dioxide, that means you have what we call dead space, or areas of lung where you're breathing, you're moving air, but you're not getting blood flow to those areas. So you're very inefficient. So this is a measure of the ventilatory or the breathing efficiency. And then these other things are things that we are measuring that have to do with how the pressures are increasing when you're exercising.
Okay.
So once we make this diagnosis, we got to figure out what we can do to help. And this is a cartoon of the sizes of the pulmonary arteries. You have to start with the main pulmonary artery, you have the lobes of the lung, and then the segments, and then the subsegments, and then the microvasculature. And the vessels get progressively smaller as you get out further. We can do surgery and operate and remove chronic blood clots from vessels all the way to about the subsegmental level. Once patients have clots that are further out than that, that are beyond the reach of our surgeons, those vessels we open up with a procedure called balloon angioplasty that I'll show you in a couple of slides. So where the clots are determines what sort of management options patients have. If it's beyond even the segmental and subsegmental branches into this microvasculature, those are patients that we use medicines to lower the pulmonary artery pressures and make them feel better and feel like they can do more. So, and we can use these things in conjunction. So we may say, okay, we'll start with balloon angioplasty, or we'll start with surgery. And if there's anything left over at the end, we can go in and get the areas the surgeon couldn't reach with angioplasty, or use medicines to bring down the pressures to make surgery or angioplasty less risky. So we use all those things in conjunction. So this is the story of the surgery for chronic thromboembolic pulmonary hypertension or chronic thromboembolic disease. So Ken Mosier here, this gentleman, he was the founder of the pulmonary division at UCSD. So UCSD is a pretty new medical school, founded in 1969. Dr. Mosier came from Georgetown in the NIH, and he was a specialist in pulmonary embolism. And he had seen patients who had chronic scars, who never got back to their pre-PE baseline. And he thought that maybe there's a way we can surgically remove these scars. Nina Brunwald was the first cardiothoracic surgeon here at UCSD. She was one of only a handful of female cardiothoracic surgeons in the 1960s. But Dr. Mosier convinced Dr. Brunwald to consider a surgery to remove the lining of that blood vessel where these chronic scars had become part of that vessel wall. And they did the first surgery in 1972. And I'm happy to say that just last month, we celebrated our 5,000th surgery. So
Wow.
this is a patient from Colorado. He's allowing us to show his name or his images. You can read more about that on our Instagram channel. But this is Dr. Medani. He's our surgeon, and he is really a pioneer in this. Really has improved the techniques, and we're able to get more distal disease out, get everything out, and improve things. This is Nick Kim. He's the head of our pulmonary vascular division. That's me, and this is our PA, Angela. And this is Jill, Dr. Medani's nurse practitioner. So
I know we have talked about at some point, I don't know if this is going to be further along in the slide or not, but how treatment has progressed and what's new, and just want to touch on all of that for everybody.
So I think the new thing is that we're using these therapies in conjunction. So we can start with surgery if you still have some residual symptoms, residual pulmonary hypertension. Cleaning things up with balloon angioplasty or with pulmonary hypertension medicines, I think is sort of one of the new things. I think it's important that I always tell doctors this. It's the surgeon holding the scalpel should be the one that determines whether or not somebody is a candidate for surgery. What I don't want is, some doctor in, rural Nebraska saying, well, I don't think they can do this. I don't think you're a candidate for this. And that patient never coming to a surgeon's attention. Because we are doing more advanced cases. We've done patients into their 80s. Our oldest patient was 87 at the time of surgery. We've done Jehovah's Witnesses who wouldn't take blood products.
Wow.
We've done all kinds of crazy things. And our experience has allowed us to, go out on a limb and do the things that we can to help patients who are in dire straits. So,
is there any difference between men and women being treated?
Women tend to have a little bit more pulmonary hypertension than men for a variety of reasons that we're still working out. But the incidence of chronic clots is pretty similar among the sexes.
Okay.
So this is, sorry for if you're queasy for the.
No. And actually, we really appreciate you bringing the slides and showing us, because so many of us never see this and don't have a, great understanding of what actually transpires. So thank you for
Sure.
sharing.
So these are the instruments here that are used. These forceps are called the Medani forceps because our surgeon, Dr. Medani, invented them. This is a Jameson sucker, and you can see that this thing is blunt on the end. And so Jameson was one of our first surgeons here. And what they do is they use these. Here's Dr. Medani holding his Medani forceps. They make about a 1-inch incision in the pulmonary artery. So it's an open heart surgery. Patients are, have breathing tubes in. They open the chest. They are on a cardiopulmonary bypass machine. So they have a big machine that's pumping the blood and oxygenating the blood. And they actually can use that machine to cool your body temperature down. Once you're cold to about like 60 degrees Fahrenheit, they can actually stop the heart and operate on these pulmonary arteries coming off the heart, going to the lungs where these chronic blood clots are. And they stop the heart so that they can drain that, so that when they open that blood vessel, there's not blood all over the field. So they've drained this blood vessel here. This is the pulmonary artery. And they make about a 1-inch incision. If you've ever skinned a chicken breast, you sort of put your finger between the skin and the meat, and the skin comes off in one piece. So what you're looking at here is the inside of a blood vessel has a muscular layer and an inner lining skin called the intima. That intima is where these chronic scars have become part of that vessel wall. And they use this blunt instrument just to continue that natural plane like you would with your chicken breast to take that inner lining skin of the vessel out in one big piece. So that picture I showed a couple slides ago of that specimen, that's how they get that out. It's just they grab it with those forceps, they extend the plane, grab it, extend the plane, grab it. And it takes a very skilled surgeon and excellent tactile sensation. If they pull too hard, it's like a rubber band, the thing can snap and you can lose that plane, and then you're never going to get it out. So you need a very skilled, experienced surgeon doing this procedure. And that's how they do it. So it takes about 20 to 30 minutes per lung. So
I was just going to ask, what was the length of time to do this?
The surgery takes pretty much all day, like 12 to 14 hours. Most of that time is cooling patients down and rewarming them afterwards. It's about 20 to 30 minutes per side where the heart is stopped that they're actually removing those clots.
This is incredible.
So this is a typical specimen, but I've mentioned all these things. It's not, you may have heard of some of these catheters where we do embolectomies, where we're sucking those red blood clots out. This is an endarterectomy. There's not much red blood clot in there anymore. It's become this scar as part of the vessel wall. We need to remove that entire lining of that vessel with that scar to reopen the blood flow to these areas of lung.
Question for you.
Yeah.
Mechanical thrombectomy is becoming more often used than it has been in the past. Obviously, it's more sophisticated. There's more devices, et cetera. Being treated with that for high-risk patients, medium to high-risk patients, is that impacting patients' ability to not get CTEPH or CTED?
I hope so. I
Any
hope so.
data
I
around
hope in
that
my
yet?
career, I put us out of business. I also run our acute PE service, and so I take patients to the lab, and we decide to which patients need embolectomy. And I hope that by being more aggressive up front, we can prevent these long-term complications. There are a couple of clinical trials among the 15 that you listed that we are part of that are looking at, does being more aggressive up front with acute pulmonary embolism prevent these long-term complications? So I hope so.
What about for DVT?
For DVT, yes, I think the same thing holds. You need to have that acute clot there, and that needs to be remodeled into that chronic scar. The one thing with DVT that makes it a little bit more complicating is you have those little valves in your deep veins that are helping blood get back up towards the heart against gravity. Those can get obliterated, and you can still have chronic symptoms even though there's no clot left. So if you're missing those valves, then you can still get swelling, still get leg heaviness, still get the discoloration, and it's not necessarily chronic clot, but just this venous insufficiency because of the damage to the valves. So yeah, I think that's a good question.
Okay.
So
And these are the different disease
these are the
levels.
different levels of disease that we can remove surgically. We're hoping that, I'm talking a lot about UCSD, but there are a lot of centers across the country. Not everyone needs to come to UCSD, but most of the centers around the country can get these more proximal level diseases. And the more experienced centers can get these segmental and subsegmental clots out. So, we're just seeing the tip of the iceberg, as I mentioned. There's a lot of centers. We don't need to see everyone. We're happy to see the sicker patients, the ones that are higher risk, the ones with more distal disease that you need a more experienced surgeon for. But I think the most important thing is that patients get diagnosed and are treated somewhere. You asked about some innovations. In certain patients, we can do a minimally invasive PT surgery. So rather than going through the sternum, through the breastbone, we can go in between the ribs, and much smaller incision, much quicker recovery. There's a lot of things that we have to look for to make sure that it can be safely done that way. But patients are scared of this big open heart surgery, and rightfully so. But I think in experienced hands, it's safe, and in the most experienced hands, it can even be done minimally invasive.
And when you say minimally invasive, is this a in hospital procedure out the same day, or is this
No, so on average, the sternotomy procedure is about 10 days in the hospital.
Okay.
The minimally invasive is about a week. So it's a couple days less, but
So it's still
recovery.
a big commitment for the patient. Yeah.
Correct. But the reason you do it is because we can cure you of your pulmonary hypertension, your heart function gets better, you can do more, and you can, you mentioned the 6-minute walk test. People they're more functional, they can walk further, they can do more. And I think that that's really important, that we get patients back to more functional ability and back to closer to their pre-PE baseline. Not only are their pressure's better and they're able to do more, you're also more likely to survive. And if you have significant right heart failure, you can die from complications of right heart failure. And by doing the surgery, we can fix that problem and extend patients' lives. So for patients who aren't candidates for surgery, we do offer balloon angioplasty. So this is a catheter that is in this pulmonary artery here. You'll see some dye, and you can see this vessel just sort of ends right here. They pass that vessel with a wire, and then at the end of this wire, they inflate a tiny 2-millimeter balloon, and they can inflate and move that scar out of the way so that when they shoot the angiogram again, you can see blood flow much further out in the periphery. So for patients who aren't candidates for surgery, or who have some smaller clots that are further out, this may be a better option for those patients.
And
Again,
why are they typically not a candidate?
Well, if these are pretty far out, and it would be beyond the reach of our surgeon. So if we don't think we can get it out surgically, this is an option.
This is the next option. Okay.
So we talked about CTED, those that don't have pulmonary hypertension. It takes a lot to decide. We look at how much clot there is, how limited the patient is, and if they have other diseases or other problems, and we review it as a team and do shared decision-making with patients. So we want to make sure that you're on board and on the decision. If you don't have resting pulmonary hypertension, a case could be made just to do nothing. And so this is data from the Papworth Hospital in London, and they followed patients with no pulmonary hypertension for 36 months, and they had no deaths and nobody progressed to heart failure in that 36 months. But patients were very symptomatic. So this is functional class. The higher your functional class, the more symptomatic you are. That doesn't get better over 36 months. You're still limited after 36 months. And your 6-minute walk distance maybe gets a little bit better, but a 447-meter 6-minute walk distance isn't great. So you're still going to be limited. You're still going to have shortness of breath. So you don't have to do surgery, but if you want to get better, I think we've shown, and this data is currently in press, that in 163 patients with chronic thromboembolic disease, no resting pulmonary hypertension, we've had 0 deaths. And the patients get better immediately. Their pulmonary vascular resistance comes down, their arteries are more compliant, and that translates to long-term functional improvements, long-term symptom score improvements. So I think there are things we can do to help those patients.
So major improvement to quality of life.
Exactly, yeah. And then the final topic is the post-thrombotic syndrome. So we talked a lot about chronic clots in the lungs and the pulmonary arteries. Post-thrombotic syndrome is the sister disease where you have chronic scarring in the deep veins. And that can cause these changes in the color of the leg. You can get ulcers in the leg. You can get this size difference and this discoloration. And this is fairly common. Things that are the biggest risk factors, if you've had recurrent clots in that leg, patients who are more obese tend to have more post-thrombotic syndrome. If you aren't on adequate anticoagulation or if your anticoagulation's been stopped prematurely, that can lead to recurrence and having more clot that sort of lines that vessel.
I can understand what would happen if you stopped your anticoagulation, but what does inadequate mean if you haven't stopped it?
I think there are patients who say, well, I want to try something natural. Todd was talking about what's the kinase?
Nattokinase.
Nattokinase that some patients have said, there's some anticoagulant effects. I don't think those are sufficient. And I would stick to pharmacologic agents that have been tested in large clinical trials. Same with I don't want to stay on, my Eliquis or Xarelto. I'll just take a baby aspirin instead. I don't think that is adequate when you have some chronic scarring there. Once you had some scar in that vessel, the likelihood of you having another clot in that same vessel is 20% higher. So if you have scarring, you need to be staying on anticoagulation to prevent that vessel from completely clotting off.
So I think that's a really important point for you to share with our community because for some folks, they're told, oh, you can come off of your anticoagulant, you were provoked, and they go on a baby aspirin sometimes, and it's just not sufficient for them. So
yeah, I think, so I run our post-PE, post-DVT follow-up clinic. And there are 2 big things that we have to do in that clinic. One is figure out why this clot happened. So that's where you're talking about provoked and unprovoked. And, is there a cancer or something that needs to be diagnosed? Doing that workup to figure out why that clot happened. And that really dictates how long you need to be on anticoagulation. If you had a knee replacement surgery and it obviously happened after that surgery and your knee is better and you're back, running marathons, you don't need to be on anticoagulation forever. But if you haven't gotten back to your baseline, we need to work that up before we stop anticoagulation. So the second thing one is why did this happen? And that really determines how long you need to be on anticoagulation. The second thing we do is, are you back to where your pre-PE baseline, pre-DVT baseline is? That's the workup that we do. And you have to be back to your pre-PE baseline before I'd be willing to consider stopping anticoagulation.
Yeah, going back to PTS, do you need to have both swelling and pain to have post-thrombotic syndrome, or
no, there are different clinical scoring systems. So there, you get points for swelling, for discoloration, for pain, for heaviness, for, the ulcers. It gets a little bit complicated how we, establish that. But I think ultimately it's all due to chronic scarring in those veins and then loss of the function of those valves. So I think those are the big things. The way we look is by doing a repeat ultrasound to see if the flow is back to normal. And the treatment is typically the best thing is compression socks. So compression stockings they do the work of those valves. So the valves are trying to get the blood flow back up to the heart against gravity. Those compression socks, they're graded compression where it's, higher compression at the distal end by your feet and less compression as you move up to sort of push the blood back up towards the heart. Those are the best things for reducing symptoms, preventing worsening. And then at night, you elevate your legs above the level of your heart so that gravity is your friend there and you can drain that circulation. The other thing that helps is contracting the muscles. So when you squeeze your calf muscles and your thigh muscles, it squeezes those veins that run through those muscles, and that pushes the blood flow back up towards the heart. So, getting out and walking and moving, that helps.
What about for the patients that always ask about, the devices that they wear in the hospital? They put them on their calves, they're pumping them. People want to buy those and have them for home. Do you recommend that?
I don't think that that's necessary. I think getting a properly fit pair of these compression stockings. I like the Jopes brand. And there's different degrees of compression. I think 20 to 30 is typical. The highest, like the 30 to 40, are just incredibly difficult to get on. And that additional compression probably isn't worth it. I like the ones that are knee high. The ones that are thigh high tend to roll down, and then they are actually pinching, at the popliteal vein here in the back of the knee, and that can cause issues in and of itself. So I think you just need knee high compression stockings, 20 to 30 millimeters, and wear them just when you're upright. At the end of the night, you take them off and you elevate your feet. That's all you really need.
And it's really better to get those prescribed, right? I mean, just
Correct,
going out and
yeah.
guessing what kind of graduated strength you
Yeah,
need
I
is
mean, you could
probably
buy
not a
these
good
things
idea.
on Amazon, but I think you're better off going to a medical supply store
Mhm.
and getting measured and getting properly fit so that they're not causing harm.
Yeah.
So
Are
yeah,
they covered by insurance?
it gets a little challenging. Sometimes they are, sometimes they aren't. A properly fit pair of compression stockings is about $50 to $70 in that range.
Right, but you don't wear the same pair every single day. You need multiple.
Exactly. So yeah, it
Expensive.
can get expensive, or you're doing a lot of laundry. So yeah. And then the final thing to mention is for some patients with post-thrombotic syndrome, if they have more iliofemoral, so like more high up obstructions in chronic scarring, they could do a similar procedure to that balloon angioplasty that I was showing you in the lung. They can do venoplasty and have a balloon and push this chronic scar out of the way and keep that vein open with a stent. Tends to happen more on the left side just because the anatomy and the left iliac vein is a little bit longer. But if you have chronic symptoms and post-thrombotic syndrome, evaluating whether you have something that can be intervened upon by one of my interventional radiology colleagues is really important, because if there's something we can do to help the situation, we should do that.
So coming back to the mechanical thrombectomy question again, is that starting to replace stents in any way or no?
So mechanical thrombectomy for iliofemoral DVT, iliocaval, like the IVC, the inferior vena cava, those more proximal vessels, larger vessels, my interventional colleagues can do procedures where they can actually aspirate that chronic clot and open up the blood flow to those areas. So whether or not you need stenting, it depends on the anatomy. So there's something called the May-Thurner syndrome.
Yes, and actually quite a few people tonight have commented that they have May-Thurner.
Yeah, so what May-Thurner is the left iliac vein. So the inferior vena cava goes a little bit more on the right side of the body. And so the left iliac vein is longer across to the left leg. And you can have an artery that sort of runs on top of that vein, and the artery is high pressure, and that high pressure artery can compress that vein and cause the vein to smush down in that left iliac. And so that's called the May-Thurner syndrome. If you have that, you're predisposed to getting blood clots in the left leg. And if they find that, then they can stent that vein open in that area to relieve that compression from the artery. Those are the typical ones that are getting stenting now. Most of the time, they can open up the blood flow just with the mechanical thrombectomy devices.
Okay, great. This was fascinating, absolutely fascinating. Thank you so much. Our original agenda format went way out the window about 2 minutes after you started speaking. What I'd like to do is, I wish I'd known that before I wrote it, but that's okay. I think we have a couple minutes left it's only supposed to be for an hour. We want to be mindful of your time. You're actually 3 hours behind us, so I'm assuming you're still in clinic, actually.
Yeah,
But
I'm fine. I'm happy to go a little bit over and answer some questions. So.
we have a lot of questions from people, so I think this is where Todd and I would like to jump in and ask. So Todd, I'm going to go first.
Okay.
How does post-thrombotic syndrome differ from chronic venous insufficiency, and how does lymphedema fit into this puzzle?
So lymphedema, chronic venous insufficiency, and post-thrombotic syndrome can all manifest as swelling in the legs. So you can have similar symptoms, but I think the reason that you have swelling is different for each of those things. In post-thrombotic syndrome, it implies that there's some chronic scar in the vein that's causing those symptoms. Venous insufficiency, it's a problem with the valves. So you can have venous insufficiency that's contributing to post-thrombotic syndrome, or there are patients who have, heart failure and they have high venous pressures and their valves are incompetent and they have venous insufficiency from a completely other reason. Lymphedema is a bit different. There's, we talk about arteries and veins. There's also the lymph system, which drains tissues. And if you have damage to the lymph, then you can get swelling in the leg that is different and separate from venous insufficiency and separate from post-thrombotic syndrome. Compression tends to help with all those things, but some of these other interventions may not be as useful.
Mm-hmm. Okay.
I've got one for you because nearly a dozen times a day we get this in the patient support group, and patients talk about this a lot. And it's the chronic, and this is more of a general question, but it's that chronic fatigue that just buries people emotionally and physically, sometimes for months. Is there a mechanism that makes that happen? What's the cause of that major fatigue, and is there anything anybody can do about it?
I think fatigue can be a symptom of chronic clot for sure. I think the other thing is, when you have a pulmonary embolism, this is a potentially life-threatening event. People have the other PTSD or the other PTS, post-traumatic stress.
Right.
And they have fear about having another event, and they live in fear. And sometimes patients, haven't been told, like, it's okay to exert yourself and to get a little short of breath and do some exercise. You don't want to do it like right away, right when you're in the hospital, but, a couple weeks after, you should start getting back to exercising. And as long as you're taking your anticoagulation, you shouldn't live in fear. You should get back to exercising and getting back to normal. And if you are short of breath, then it's incumbent upon your doctor to work that up. And we should really be able to tease apart, chronic fatigue and this post-PTSD after a blood clot from what is a physiologic limitation from scarring of that initial blood clot. That's the whole point of that whole algorithm that I work patients through is, 50% of people are short of breath, but not, it's not the same 50% of people who have chronic clots.
Right. Thank you.
Interesting. And this is really quite fascinating. Is numbness in your foot and toes part of PTS?
So it can be. You can have some neurologic problems as part of it, depending on how swollen the leg is. So yeah, it potentially could be related.
Okay.
So real quick, a real popular question every day. How can we tell when the clots are gone if the doctors don't actually do a retest or a rescan?
So I think most of the time, the blood clots are gone. If you don't have symptoms, so if you're back to your pre-PE baseline, I don't think you need another scan to prove it's gone. If you have symptoms, yes, definitely, somebody needs to make sure that that clot is gone. You're not going to get chronic thromboembolic pulmonary hypertension or post-thrombotic syndrome or anything if your leg is back to normal or if you're back to your pre-PE baseline. So it's only if you have symptoms and you're not back to your baseline do I think you need a full evaluation to see if that clot's gone.
Yeah, if you don't have symptoms, it's just not going to up on you a couple of years later all of a sudden.
Exactly.
It's gone. Okay.
Okay.
Thank you.
Do these conditions begin right after the instance of a DVT or PE, or could they potentially not show up until years later?
So that's a really good question. So in terms of chronic thromboembolic pulmonary hypertension, there have been a number of studies trying to figure out what the incidence is after a PE, and they would follow patients at set time points. The best done study was done in Italy, and they followed patients every 6 months, and everyone that developed pulmonary hypertension by 2 years. So most patients are presenting even earlier than that. And if it's gone 2 years and you don't have pulmonary hypertension, you're probably not going to develop pulmonary hypertension much longer after that. But yeah, I think the resolution should happen very quickly. In that first month, patients should really be feeling a lot better after their incident PE. They should be feeling a lot better in that first month. If you're not feeling better by 3 months, then that needs further evaluation.
Okay, great. Todd, how about one more piece and then we need to let Dr. Fernandes go back to work.
Yeah.
We have some exit questions as well.
Yeah, we'll do a poll here in just a second. So somebody was asking if they're diagnosed with CTEPH and they don't really get any treatment, is this something that can resolve on its own over time?
So no, I don't think so. I think CTEPH especially tends to progress, tends to get worse. You can eventually develop heart failure. It gets back to that analogy of putting your finger over the end of the hose. That pressure gets high and the heart is pumping against that high pressure. Over time, the heart can fail and patients can start passing out. They get more swelling, and that can be a fatal event. So I think it's really important, and I want to find patients earlier. One, because the sooner we find them, the sooner we can help them, and the sooner we can treat them. And two, if we wait until they're more symptomatic and their pressures are higher, then the risks of some of these interventions go up. So trying to find patients early before they're in overt heart failure makes the surgeries and the angioplasties and the medicines, everything works better if we find patients early.
No, we're sure lucky to have you out there because I wish I wish you were like everywhere because
Totally.
you answer so many questions that people have had, and I think you're just all around very informative. So thank you so much for being here.
Yeah, thank you to Leslie and to you, Todd, for reaching out and inviting me. I really appreciate it. I keep up the good work. I want patients to know, I believe you. I believe that you're short of breath, and I believe that there are limitations. And I think, hopefully we can find doctors around to work these things up for you, because I don't think you should be suffering from this. So, if I can be of help to you guys or anyone, my contact information's there. Feel free to reach out. I'm happy to help. And there are, even if it is, hey, do you know a doctor in Minnesota or somebody,
Right.
somewhere where I can go to be evaluated?
Patients in the group ask that all the time. Do you know anybody in
I'm
the
happy
area
to
because they can't find anyone?
facilitate those sort of things because I want to help
Yeah,
people.
and if people have questions, they can come to us at NBCA and we can facilitate the conversation so you're not
Yep.
inundated. But that would be incredibly helpful. I'd like to get a commitment from you tonight that you'll be back to continue this conversation because
Happy to do it.
it warrants more conversation, and also to say thank you for being so supportive of patients and saying, hey, we do believe you.
Yes.
And it's a bummer to have to find new doctors and keep going back to get answers. So we appreciate that very much from you. So with that, before you jump off, let's do our exit questions. And then we'll call it a night. And thank you for staying on a little bit longer.
Thank you.
Yeah, thanks
Right.
to everybody. As soon as these fire up, okay, here we go. Exit poll. Would you like more information from the MBCA about CTEPH, CTED, and PTS? Yes or no? Do you feel you have a better understanding of CTEPH, CTED, PTS after tonight's event? Yes or no? Last question. Would you be willing to take an NBCA survey at a later date about your experience with CTEPH, CTED, and PTS? I love surveys. Yes, no, or no answer. If you could just answer those real quick. We will review them before we say goodnight to you.
I wish I could vote.
I know. I keep trying. I keep trying to click on.
Because I know
can't
I
do
learned
it.
a lot tonight.
We learn something every pep talk.
Oh.
Post poll. Here we go. Number one. Would you like more information from the MBCA about CTEPH, CTED, and PTS? 89% said yes. Do you feel you have a better understanding of CTEPH, CTED, PTS after tonight's event?
Wow.
100% said yes. We like that. And would you be willing to take the
I did a good
MBCA
job.
survey? Yes, you sure
Coming
did.
back.
Would you like to take a survey? Would you like to be kind of involved in that? 73% said yes. So, yeah, back there at corporate, let's go ahead
Awesome.
and get that survey ready to
This
go.
was fantastic. Dr. Fernandes, thank you so much. Todd, thank you.
Thanks,
Thank you.
everybody.
Good night,
Bye-bye.
everybody.
Good night.